So just concentrate. I will not give any polls until at the end. If there's time, I'll give you some 2 past MCQs. Otherwise, no. Right. Hypertension is high blood pressure, as I mentioned in the morning, and it is persistent or sustained elevation of systemic arterial pressure over 140 systolic and 90 millimeters mercury diastolic. So if somebody has either systolic pressure over 140 or diastolic pressure of over 90 millimeters mercury, that is considered hypertension, even if you don't have both. However, it has to be sustained, okay? Just one single reading is not really considered as high blood pressure. Now, the thing is, it's common and this leads to target organ damage if not treated properly. You know, blood pressure is determined by cardiac output and systemic vascular resistance. And peripheral resistance depends mostly on caliber of arterioles. And baroreceptors are reset at a higher blood pressure in chronic hypertension. You saw this in the morning. This again you saw in the morning. So let's discuss the principles of management according to this. So we know blood pressure is determined by cardiac output and systemic vascular resistance, which is dependent on mainly caliber of arterioles. And cardiac output is on heart rate and stroke volume, and stroke volume is mainly dependent on venous blood volume, which determines the preload. So the main treatment methods are these three. We are addressing these three factors. We like to increase the caliber of arterioles. We try to reduce the venous return or the venous blood volume, and we try to reduce the heart rate. So these are the usual principles of management. Okay, now I'm sure it is very clear to you up to now. And also we could try to reduce the afterload, that is by dilating the caliber of arterioles. Okay, so because he is very well interconnected, and so anyway, let's come to that. So what are the causes of hypertension? Well, the commonest hypertension or high blood pressure you find now in young adults even, it's multifactorial, common, it's very common, and usually it has no symptoms. People just go with having high blood pressure for some time without knowing that you're having it. The reasons could be numerous: lack of exercise, obesity, stress. Those are the common, and genetic influences. Those are common multifactorial the causes of high blood pressure. So just remember to avoid these, because just giving a medicine is not enough, because most of these, except genetics, most of these are correctable. Kidney diseases will cause hypertension because they can cause an increase in renin secretion. And you know, renin causes stimulate the secretion formation of angiotensin 2 as well as aldosterone. Angiotensin 2, as you remember, causes vasoconstriction, fluid retention, right? And other means increases peripheral vascular resistance and fluid. And aldosterone causes fluid retention and increases the preload. Then there's hormonal overactivity, such as aldosterone, glucocorticoids, catecholamines, growth hormone. Now, you know, if you have high aldosterone, you get lots of fluid, sodium, and water retention, increasing the preload mainly. And if you have catecholamines, you get, that is sort of sympathetic activity, and that can increase vasoconstriction, heart rate, contractility, etc. The others, you don't have to know the mechanism just yet. Glucocorticoids and growth hormone, you will learn later on. Coarctation of aorta, you have learned in anatomy, I suppose, that causes upper body hypertension. Increased blood viscosity in severe polycythemia can give rise to hypertension. There are medicines commonly used, oral contraceptive pills, and cocaine plus other things can cause hypertension. And pregnancy-induced hypertension occurs due to, again, various reasons in otherwise healthy people who are pregnant. And there are other causes. But remember, I mean, around 90% of causes or maybe more will be because of these essential hypertensions, which is treatable and preventable. And so remember that now, because you all are all sitting, eating, having stress. So you all are medical students and doctors are high candidates for essential hypertension. Now, principles of management, I showed you what we are generally trying to do: increase caliber of arterioles, reduce venous return, and decrease heart rate. You know the mechanisms, you know how it can be done. So principles of management, you can cause vasodilators. They can do two things. One, I have written here, decrease systemic vascular resistance. What else can they do? Vasodilators can decrease afterload, right? So that is another thing. And then mainly by calcium channel, if you block calcium channels, that will prevent smooth muscle contraction. Then angiotensin converting enzyme inhibitors. If you remember in the last lecture, I showed you angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, mostly from the lungs. Now, if you block this ACE, then you don't get angiotensin 2, and that will help in reducing high blood pressure. And angiotensin 2 receptors, or they are in the tissues, in blood vessels. So if you block them, angiotensin 2, even if formed, it will not be able to act. Alpha receptor blockers will help in vasodilation because alpha receptor stimulation causes vasoconstriction. Beta receptor blockers will act by decreasing heart rate and contractility. Because beta receptors in blood vessels are actually vasodilators that cause vasodilation. So it is not that mechanism, but it is by blocking heart rate, reducing heart rate and contractility. So which beta receptors would you like to use? Generalized beta, all beta receptors, beta 1 or beta 2? What is there in the heart? Just think. It's beta 1 receptor. Yeah, beta 1 receptor blockers are selective. So if you give that, you can allow skeletal muscles to vasodilate with beta 2 receptors and still reduce heart rate and contractility. And there are diuretics. I mentioned this term in the morning. You can reduce the blood volume by increasing urine output. Okay? You will learn about diuretics in next term. But remember to put it together as an antihypertensive to reduce high blood pressure when you come to next term. Right now, you don't need to know any additional details because reducing blood volume will reduce both preload as well as afterload, mainly preload. Then there are other things. Same vasodilators, all these will dilate veins as well. Okay, they can act as venodilators and then, increase venous pooling and prevent venous return. But these are the main mechanisms. So that is why I have given them here. Okay, hypertension done, finished. So you know the basic principles of high blood pressure, how you get high blood pressure, what are the likely causes, and what are the principles of management, and what medications can be used. By the way, there are lots of other medications also being used, but these are the common ones that are used. Go and check your parents, family members' medication now. Now, next one is ischemic heart disease. Ischemia means tissue damage. The tissues get lack of blood supply and lack of oxygen supply. So basically what this means is inadequate blood supply to heart muscle to satisfy its oxygen requirement gives rise to ischemic heart disease. Now, what are the causes? What will prevent the blood supply to heart muscle? One thing is a block, mechanical obstruction to the coronary blood flow. This is the commonest cause. Now, that is seen with atheroma thrombi. Now, you have heard so many people having heart attacks, coronary heart disease, what people call coronaries. Usually, that is because there is the atherosclerotic plaque. There's a sort of a thing blocking the blood vessels, which are physically, mechanically blocking it, blocking the blood flow. Then there could be non-mechanical reduction of supply of oxygenated blood to the myocardium. You know these reasons. I'm just putting it together. One is, imagine if you have severe anemia, normal hemoglobin is about 12. Now, I have seen a girl with HB of 3. I don't know how she did. The thing is, she was getting chest pains, young girl, which she was getting chest pains on walking because her hemoglobin is only 3 grams per deciliter, whereas a normal person has 12. Okay, so therefore, there's not enough oxygen supplied to the heart muscle, especially during exercise. Then other thing is low blood pressure or hypotension. Now, if your blood pressure is very low, that reduces the perfusion, tissue perfusion, including the perfusion of coronary vessels. I'm sure you must have learned this with circulation through special region. And very high tachycardia, that is, if the heart rate is extremely increased, very, very increased, you know, ventricular filling mainly occurs, passive filling occurs in diastole, and diastole becomes very short in tachycardia, right? So there is reduced diastolic filling and end diastolic volume and stroke volume, plus the heart has to work very hard with tachycardia, breathe frequently, so oxygen consumption is also increased. So therefore, heart muscle find it difficult to be oxygenated and develop ischemia. And the other thing is, third one I'm coming to that, increased demand for oxygen by the myocardium. Say severe tachycardia, if someone has, now what is your normal heart rate? It's around 60 to 70. Now, if someone persistently has a heart rate of around 200 for some time, then after some time, the heart is unable to receive the blood. That is, the cardiac muscle is unable to receive the blood due to multiple reasons. And the patient might get ischemia and ischemic heart disease. Or in conditions like thyroid hormone excess, hyperthyroidism, where again, you get hyperdynamic circulation. The blood flow is very fast. When the thyroid hormones are in excess, things become very fast forwarded in the body, and therefore it's unable to supply oxygen to satisfy the demand. But remember again, the commonest cause is the one that's in red. That's obstruction. Again, 90 to 95% is because of mechanical obstruction. Right, okay. So this is the reason for the commonest cause. You can see the endothelium. This is the vascular lumen. This is the endothelium. These are the vascular smooth muscles. Now look, see what has happened to this person. Don't worry about all this. Here you have got an atherosclerotic plaque deposited. There's a plaque. There are inflammatory cells, macrophages, neutrophils, other cells, right? T cells. And there's inflammation going on, and it's getting bigger. And one fine day, you can see necrosis, necrotic core here, all dead cells and stuff. And then one fine day, when the plaque becomes bigger, it pulls this and it ruptures. When there's an injury to the blood vessel, you know, there's a thrombus formation. So this is what happens. People with narrowed blood vessels are going there, you know, they are functioning, they are doing things because they are used to this. But then one fine day, this plaque ruptures and suddenly they hold the chest and they get, oh my God, I got pain, because suddenly there's a platelet plug and a thrombus clot formation, which is totally, really maybe block it very, very much. And then you get a sudden loss of blood supplying the myocardium, and you are going to get ischemic heart disease. Now, this is atherosclerosis. This is a baby's artery, a newborn baby's artery. Look how beautiful it is. You got cholesterol in the, it's floating there. This is happening when you are still, you get little bits of cholesterol being deposited. This can happen in childhood if you're having all the burgers and the, Pizza Hut stuff and the McDonald's stuff, or you're having just bread and bread and butter or whatever. so cholesterol starts depositing. And this build-up begins, this is starting in young adults, okay? You all are young adults, so the build-up actually has started. So please make sure that you exercise and keep on having good diet. And now these are the actual mature, I mean, don't worry, you all are not going to have atherosclerosis, but I'm just saying it has started. And so maybe in 20s, 30s, it's going to be like this. But plaques keep forming, and this is a bad plaque, atherosclerotic plaque. So I probably am somewhere here. And I hope I have exercised and I'm like this, but I don't know, right? So this is if you take the other section, this is a nice clean artery with no plaques, later on bigger plaques, then suddenly plaque rupture. See, here the blood flow is less, but here the blood flow has stopped. So now you are going to get lack of blood supply and ischemia. In situations like this, you will get reduced blood supply in exercise. Right? So they will say, oh, I'm tired, or I got chest pain when I'm running or whatever. But here, even at rest, you are going to get a reduced blood supply and pain. So the effects of ischemic heart disease, this just shows some sort of blockages, right? 30% blockade, most people in 30s, 40s will have things like that. Then 50% blockade, still okay, you are managing, you're still running, exercising, doing your jogs. 90% blockage, you're not really able to do jogs, you are getting tired. 99%, yes, you are still working, right? Coming to jobs, you know, you're driving your car, that sort of things. But 99% block, you are in real trouble. You can't even do normal things like that. So, how will you know someone has myocardial ischemia? One thing, it could be chest pain on exertion. It can happen here in situations like this. This is called angina. Or there could be a plaque, unstable plaque now, which is about to rupture, or maybe it's rupturing. That is called unstable angina, because someone who was just getting chest pains or shortness of breath when climbing stairs or climbing a hill now is getting pain all the time, even walking, when walking just, you know, on a road or whatever. So this is worsening pain, and that's unstable angina. And one fine day, still the muscle is not dead, okay. One fine day, there could be death of the myocardium in a situation like this. There's a block, total block, no blood going there. And that is called myocardial infarction. This is a myocardial infarction. This is dead zone of infarction. But this part is salvageable. We can save this. If we increase the blood supply immediately, we can manage by saving quite a lot of area. The dead muscle, we can't really make the dead muscle come back alive. So we have to, the treatment principles is you are going to make sure that this area is going to be reperfused soon, right? Prevent further extension of the death of myocardium. So what will happen? Now say someone has got ischemic heart disease. One thing you can have is ECG abnormalities, right? ST segment elevation, T wave inversion, Q waves, etc. You will learn a lot more of this tomorrow in the IDA. I have already sent you the link because a medical doctor, lecturer, a young lecturer is coming and he will show you the relevance. When you get ischemia to the heart muscle, the normal enzymes and proteins which are inside the myocardial cells, for example, troponin, creatine kinase, right? They will leak into the blood. So you will have high blood levels of some enzymes. There are quite a few enzymes, but troponin is the key enzyme, right? You know troponin, you have TIC, if you remember your troponin in term 1, but troponin is released and you can detect it in blood. The person can get heart failure. Heart is unable to pump to satisfy the rest of the tissue demand. Or you can get abnormal rhythms, which are called arrhythmias. Abnormal rhythms, arrhythmias. There are other things. I'm giving you only the key findings. I hope you are okay up to now. Now, this is a normal ECG. This is an ECG of a heart attack or a myocardial infarction. Just have a look, compare and see what is the main thing that is striking you. Again, tomorrow we are addressing this, so I'm not going to go into finer details. What is the main abnormality which is staring at your face when you look at this? Yeah, I know you have found it. These V1, V2, V3, V4, V5, V6, look at the ST segment. The ST segment is going to, it's like this. Now it's really gone up. This is a ST elevation myocardial infarction, a bad one, patient, bad, lots of areas, okay, V1 to V6. Lot of area is affected. Good news is, bad news is it's a bad heart attack. Good news is if this patient is in hospital within 3 hours, you can get the blood back there and probably reverse this almost 100% back to normal. I know this for sure. My father had this reversed 100%. Okay, so if you see someone with chest pain, this sort of ST elevations, get them to the hospital. Don't let them move, carry them, right? Don't let them exert, because exertion needs more oxygen, requires more oxygen, increases oxygen demand. Just carry them wherever, right? Bring to hospital, give an aspirin or whatever, and bring them to hospital. Immediately, you might be able to reverse all this and get the heart back without any significant muscle damage. Right. Now, something about cardiac markers. Just follow me. I have only given 2 things. Troponin and creatine kinase. This is MB fraction, right? Creatine kinase. These are 2 things which are usual inside a myocardial cell, which leak out when they are ischemic. Now, this is days after the onset of symptoms. These are the various values. Don't worry this. Just look at the days. Now, if you just take this one, in a normal person who had a heart attack, the troponin will go up, but it will keep going up and it will remain up for maybe a week, maybe even 10 days, okay? So the troponin is going to remain high. So even someone complains of chest pain, 2 days ago, you are still not sure, but still chest pain, you get them to get the troponin done. And if it is high, oh my God, immediate admission, because now you need to do something, right? Some people don't have massive chest pains, I mean severe chest pains to bring the person to hospital immediately. But you can do the troponin because it's going to remain elevated up to about a week. Now look at this light blue line. This is just troponin. Now this is the troponin after you brought the patient to hospital and you somehow or other gave back the blood supply, reperfused. Look, the troponin has become even higher. That is because now the blocked areas have opened up and the troponin that was from the dead muscles is coming out fast. So this will show you that the reperfusion has occurred. Okay, good news. Same here, you can see CK, creatine kinase, it will go up. It will usually go up within the first day and come down fast. Now with reperfusion, that also will go up because now the dead cells are reperfused and the creatine kinase which were inside them are now coming into the systemic circulation and you are checking it in the blood. Right? So blood levels, if the levels are very high, you know the severity of the heart attack or ischemia is greater. Right? Because more cells are damaged, more troponin leaking. So this will show you the presence as well as the severity of ischemia. Right, this I mentioned. So let's come to the principles of management in your terms. If you give vasodilation, nitrates, nitric oxide, you know, is a vasodilator. You can give many medicines immediately. You know, if you have heard about a tablet under the tongue or a spray under the tongue, glyceryl trinitrate, that will help release of nitric oxide and immediate vasodilation. You want the coronary blood vessels to dilate and get some more blood into those blocked areas. Very helpful, give immediately. Increasing oxygen supply, you can just put the oxygen mask and give oxygen, 100% oxygen, and try to get more oxygen to tissues which are really lacking oxygen, helpful. Fibrinolytics, you know about tissue plasminogen activator inhibitor or which is called alteplase or tenecteplase or streptokinase, or there are lots of other names, okay? So all these will cause the lysis of the clot. You learned it in the hematology module just maybe about 2-3 weeks ago. Fibrinolytics are very helpful. If they are given immediately within 3 hours, you can reperfuse, you can lyse that clot, okay, which you saw earlier. Antiplatelet therapy, simple aspirin, dispirin or aspirin or clopidogrel, there are other medicines. If you give it immediately when someone is having a chest pain and you are suspecting heart attack, if you just give them aspirin or a dispirin to suck or drink, swallow, dissolve it and give, that might immediately get absorbed and prevent the platelet plug formation, and you might save that patient. Okay, still medical students, you can do things. Now you are learning the principles. Antithrombotics, that is, for example, heparin. Heparin prevents thrombus formation. So now in these patients, thrombus is formed, but you don't want the thrombus to extend. So if you give antithrombotics, for example, heparin, especially low molecular weight heparin, that will prevent thrombus extension. Reducing myocardial oxygen demand, if you give beta blockers, especially beta-1 receptor blockers, you can reduce the work of the heart, cardiac work. That is why I said if someone is having a chest pain, don't let them move, carry them, right? So because then you reduce myocardial oxygen demand. Reducing cholesterol deposition and stabilizing those atherosclerotic plaques. There are medicines called statins which will do that. Pain relief, you have heard about morphine. Pain worsens stress, pain worsens the patient's distress and increases heart rate. So you can give pain relief and the patient that will prevent worsening. And finally, and most importantly, reperfusion of the ischemic myocardium. You can reperfuse by giving fibrinolytics, or you can actually physically push a probe or whatever. You can do an angiography and physically you can break the clot and you can put in a stent, or you can even do an immediate emergency bypass grafting to bypass the clot and the thrombus and supply blood to the area that is ischemic. Right. All these are done. Now I hope these all, except for statins, you know all these, the mechanisms, it's logical. So you can work it out. We'll come to this again tomorrow, okay? Remember this and come. Right, so we finished hypertension and ischemic heart disease. A little about heart failure. You again already know that. Inability of the heart to maintain a sufficient cardiac output to meet tissue demands. A certain cardiac output is needed for you to satisfy tissue demands. Various names, you can classify them as acute sudden ones or chronic long-term ones. Or you can classify by the ventricle involved, right ventricular failure or left ventricular failure or right ventricular failure, or whether failure involves both ventricles. Or you can describe by using the phase of the cardiac cycle. Is this a systolic failure, or that is a failure to pump out? Or is it a diastolic failure? That is the failure to fill left end for ventricular diastolic filling. Is it a high output failure? The heart is pumping so hard that after some time it fails. Or is it a low output failure? That is in any type of heart failure. Generally, all these are low output failures. So let's talk about some of these. You know this again, in and out, law of Laplace. P equals to T over R, and therefore the wall tension is equal to pressure, intramural pressure, radius divided by 2. So if someone's radius increases, heart dilates, then what is going to happen? Wall tension is going to increase, right? Wall tension is going to increase. To produce a given pressure, because if you don't get adequate pressure, you can't pump out blood. However, when the wall tension increases, the heart has to work harder and it needs more oxygen. Okay, but now the heart has failed. It's a dilated heart. It's not pumping enough. So where can we get oxygen? So the heart is unable to meet oxygen demand. So heart failure worsens and it dilates even further, right? And that will worsen the tension, reduce the pressure. I mean, it's just going on and on like this, unless you try to reduce the diameter, reduce the radius, okay? Try to make the heart smaller. How do you make a left ventricle smaller? Yeah, you reduce the volume, you reduce the venous return, you reduce the blood volume, try to reduce it a little bit so that the left ventricle, the ventricles will become smaller, left or the right ventricle will become smaller, reducing wall tension and increasing intramural pressure. Simple principles. So heart failure, you know the Frank-Starling relationship. This is just recall. And you know this is a normal heart. This is heart failure. And this is a bad, fatal myocardial depression. This is fatal. The patient is going to die. Right? So you can see early heart failure, you will get shortness of breath. That is dyspnea. Later on, you will get pulmonary edema if it is left ventricular failure. Now, what are the types? Just, I'm not describing everything, okay? Just, you can work this out. Systolic failure, diastolic failure. Systolic failure, what happens is, pathophysiology is, contractility is impaired, and so pumping out is impaired. So, in diastolic failure, stretching, ventricular compliance is decreased, so diastolic filling is going to be decreased. You can't stretch the ventricles. So in systolic failure, you can't contract well, so the heart is dilated. In diastolic failure, heart is stiff. So it's not really dilated. It's stiff. Heart size is increased. Heart size may appear normal. Stroke volume, cardiac output is reduced, whether it's systolic failure or diastolic failure, because here the pumping is failed. Here, the filling is reduced. Ejection fraction is going to be reduced early in this one, because contractility is the main thing that determines the stroke volume, right? One important thing. So here contractility is reduced, so the stroke volume is reduced. Heart is enlarged, ventricles are enlarged, so end diastolic volume is increased. So stroke volume divided by end diastolic volume is going to be reduced. However, in diastolic failure, heart size is normal or it could be stiffened, right? So therefore, end diastolic volume is not significantly increased. And ejection fraction is in the contractility is also okay. So basically, you can eject the blood that is there in the ventricle. So initially, ejection fraction will be normal. The normal heart. This is a dilated left ventricle. You can see it's a sick one. This is again a sick one. This, you know, this thickened even further. Ventricle may have become smaller, but if you take you can't look into the ventricles unless you do echocardiogram. But if you clinically, you can assess the heart size. If you do it clinically or if you take X-ray, the heart is not dilated. But if you do echocardiogram, you can see that it's a stiff ventricle. Now, two more important things, left ventricular and right ventricular failure manifestations. You will see sometimes people are in hospital, they are breathing like this. They are not lying down. They are having not one pillow, 2, 3, 4 pillows because they can't breathe when they lie down. Okay? So sometimes they bend forward like this trying to breathe. So this is a feature of left ventricular failure. Why is this happening? Cardiac output is reduced. So blood is getting collected in the left ventricle. Right? So cardiac output is reduced. The person is tired. Person feels faint. Can't do normal things because normal tissues don't get enough blood supply. However, what is going to happen? Left ventricle is full of blood, so the pressures are going to increase. Pulmonary venous pressures are going to increase, and you're going to get pulmonary venous hydrostatic pressure increase, and you're going to get pulmonary edema. Remember your Starling forces. Okay, so pulmonary blood vessels are congested, pressure is going to increase, and you know, it's really bad when you lie down. What will happen when you lie down? When you lie down, because of gravity, you're going to get even more blood coming into the lung, about 400 ml extra. So people will have no space to breathe, no, because it's already congested. You get pulmonary edema, alveolar edema, and these people are coughing, and sometimes blood vessels rupture, and they have blood-stained sputum, right? This is a normal chest X-ray. Look at this chest X-ray in a person with left ventricular failure. All this is, you know, it's clear because it's air, but here it's full of fluid, alveolar edema, pulmonary edema. Look at that, and you can see the ventricle. This is a normal ventricle. This is really enlarged. Okay, left ventricular enlargement. Right, now if you come to right ventricular failure, cardiac output is low, so it's reduced. Tissue perfusion is reduced, because even if you get right ventricular output is reduced, that means the left ventricular output is also going to be reduced, right? So you are going to have, again, tiredness, apathy, or faintness. Now, right ventricle is directly linked to the right atrium and the venous system. So your jugular venous pressure is increased because right atrial pressure is increased. And because systemic venous pressure is increased, you are going to get edema of your legs. If you remember Starling forces again, now you apply this to systemic vein. Jugular venous pressure, instead of you usually seeing it here, now you will see the jugular venous pulsation somewhere here, maybe even up to this. Okay, they are going to be filled with blood. Look, this patient is having, you can see the veins, they are all distended, and the JVP, if you look closely, the beating is going to be here. Look at this patient's leg edema. Right? You are just pushing with the finger. Look, they are really swollen because this person has right ventricular failure. Okay, now if you just look at CVS regulation, which we did this morning, 3 organs, heart, blood vessels, kidney, and these are the things: peripheral resistance, venous blood volume, total blood volume, heart rate, contractility, stroke volume, and cardiac count, right? These are the things that are in regulation. So in heart failure, you have seen this, right? In heart failure, your blood pressure is going to be low. So basically, you are going to have as compensatory mechanisms, increased heart rate and contractility, vascular constriction, renal sodium and water retention, you may be thirsty. But, right? But the thing is, these are initially okay. But with heart failure, if these keep on happening, then what is going to happen is you are going to have a lot of fluid retention, you are going to have vasodilation, you are going to have increased end-diastolic volume, and you are going to have ventricular dilatation. That's bad. And peripheral vasoconstriction is really going to increase the afterload. So heart pumping is going to be very difficult. And so, principles of management. You try to decrease the preload and the afterload, both. Decrease venous congestion by getting rid of fluid from kidney diuretics. Or you can reduce venous congestion by giving venodilator. So blood is not coming back to the heart, but remaining in the veins. Or you can give aldosterone antagonist. Okay, don't worry about that, right? I'm just putting this. You can learn that later on. Or you can decrease afterload by decreasing peripheral vascular resistance by blocking the effects of angiotensin. Angiotensin is a vasopotent vasoconstrictor. So what you do is you can give angiotensin converting enzyme inhibitors I mentioned before, prevent angiotensin 2 formation. Or you can give angiotensin 2 receptor blockers, which will prevent the action of formed angiotensin II. Look, these are only some of the methods which you can work out using your current knowledge. I'm not giving you all the principles, okay? You can improve cardiac muscle contractility. Digitalis, you know how it works. If you don't know, if you can't remember, please go back and check. Increases calcium, myocardial calcium, okay? And angiotensin converting enzyme inhibitors do it. Don't need to know the mechanism. They increase cardiac contractility. Or you can get improve the symptoms of the patient because the patients are very distressed. There are various ways like reducing pulmonary congestion because breathing is the problem. You can give diuretics and get rid of fluid in the kidney. Beta blockers reduce mortality. Mechanism of action not clear. You can't work it out right now. So just concentrate on things you can work out. Right, so we finish heart failure. Now again we are coming to the nearing the end. One more condition, right? I can't give you a breather because not enough time. I need to give you time at the end. One is shock. That is, now say also, this is the fourth condition, inadequate tissue perfusion with a relative or absolute inadequacy in cardiac output. What does this mean? It means tissues are not perfused enough. It could be because heart is not pumping well, like in heart failure. Or it could be heart is pumping well, but there are some other reasons. Let's see what they are. One thing is heart is unable to pump well because the person is having low blood volume, hypovolemic shock, inadequate intravascular volume. Or it could be obstruction to blood flow in the lungs or heart. It could be an obstructive shock. I will come to that later on, right? It could be inadequate pumping action of the heart, cardiogenic shock, which I described earlier in heart failure. Or it could be that pumping is okay. Your stroke, the heart is pumping well, cardiac output is normal, but this person has vasodilation. Now that has caused increased vascular system, and therefore blood is quickly going down all the blood vessels, so the blood pressure is not being maintained. Now this has a lot of other names. So just let me give you a few examples, you will understand. Hypovolemic shock means either bleeding, blood loss, trauma, diarrhea, burns, vomiting, severe vomiting, you get hypovolemia. Cardiogenic is, myocardial infarction, heart failure, or abnormal rhythms can cause cardiogenic shock. These are some reasons. Obstructive, tension pneumothorax or cardiac tamponade. Have you heard about them? I think you have in anatomy. Or it could be pulmonary embolism. In tension pneumothorax, there's a lot of air being collected in the pleural cavity under tension, and it's pushing the heart, pushing the ventricle, and ventricle is not able to fill. Cardiac tamponade is there's fluid or whatever blood or fluid collected in the pericardial in the pericardial space. Right? This is a pleural space, this is a pericardial space, so the ventricle cannot fill properly. So this is obstruction to the normal flow. Or it could be pulmonary embolism. That means a big clot has blocked the pulmonary artery. So the pulmonary artery cannot transmit blood. So the person is having not enough blood coming to the left side of the heart. The last one, you're having enough cardiac output, but the cardiac output from the heart is normal, but the distribution is lots of area to distribute. For example, blood vessels are dilated. Uncommonly in severe brain or spinal injury, this can happen, but more common is anaphylaxis. Right? Have you heard about anaphylaxis? You may have heard people being given injections of penicillin or getting some injection and then suddenly collapsing. It was seen even with COVID injections, okay? So suddenly, because then all of a sudden there is a immune mechanism, IgE mediated, you are getting vasodilation quickly, right? And you fall. And if you don't, treat it immediately, you don't have enough blood going to the tissues and you die. Or severe sepsis, you can get various vasodilator mediators causing vasodilation. So the pumping is not enough. You learn about shock in the foundation module next year. Right. Now this is for you to think. I'm not going to check this because we will talk about this tomorrow as well. So what happens to the following in hypovolemic shock? One thing I can just, I haven't given you anything here, right? Just discuss with your friends. What do you think will happen to heart rate when you have low blood volume? You saw what will happen when the blood volume or blood pressure is low. Heart rate increases. What will happen to the systemic vascular resistance when the blood volume is low? Through reduced baroreceptor discharge, through activation of RVLM, you will get sympathetic activation and vasoconstriction. What will happen to urine output? Well, you still don't know, but well, I told you, like if you have low blood volume, just you can just fast and not drink for some time, you will realize your urine output is going to be reduced. What is going to happen to the skin? You answer the question MCQ in the morning. The cutaneous blood vessels will constrict with the sympathetic stimulation, and you are going to have a cold skin. You are not getting blood, it's not warm, and it's going to be a pale skin, right? Not enough blood. So skin will be cold. Respiration, the person will try to get more oxygen in and the respiratory rate is going to increase because you are trying to, now you are in shock, right? Tissues are not getting enough blood supply and oxygen. So body has mechanisms, you stimulate anoxic chemoreceptor stimulation and increase the respiration. And various hormones are going to be secreted, for example, adrenaline, noradrenaline, all that, okay? So this you can work out and you can think about it. We will discuss later. Yeah. Okay, and you can come back to this when you do renal module. This is just a picture to show you. Now imagine someone who could be someone who has fainted or someone is really collapsed, right? So when person collapse, you will see the conscious level is reduced. Imagine it's a faint. I mean, it's worse than a faint, okay? Severely dehydrated, severely bleeding, fainting. Confused, unresponsive, sweating. Sweating is a sympathetic activity. The respiratory rate is increased. That's called tachypnea. Blood pressure is low. It's hypotension. Heart rate is increased. Tachycardia. Pulse, if you feel low volume pulse. Peripheries, there's cyanosis. Right, vasoconstriction, cyanosis. It's very cold if you touch. Cold, clammy. It's wet because of sweating, and urine output is reduced. This is just an outline. Just imagine this person. Now we have finished shock as well. Just touching on some investigations. This is very light. We can finish in another 5 minutes. One is echocardiography. You do it like this. It's you send sound waves and they reflect and go back onto this probe, right? So pulses of ultrasonic waves are emitted from a transducer. You saw the transducer and they're reflected back and with acoustic impedance changes. And they are received by the same transducer and you get a picture like this. Brilliant. You can identify, okay? Right atrium, right ventricle, left ventricle, left atrium. Well, look, you don't have to do this at this exam. So don't memorize. So you can visualize cardiac chambers, valves. You see valves here, right? Tricuspid and mitral valve. And different axes of the heart observed. You can see the other side as well. You can calculate ejection fraction because you can see the ventricular size, you can see the ventricular size in diastolic volume, you can see the systolic volume, so you can easily calculate the ejection fraction, and you can visualize chambers, the flow in the chambers with color Doppler, one color when the blood is going one way, the other color when it's going the other way. This is an actual echocardiogram. Can you see? It's moving fast, okay? You can see, these are ventricle. I don't know which ventricle. These are an atrium. These are major blood outlet, probably aorta. This is the semilunar valve. These are the AV valves, okay? So all these, the images could be frozen, and you can visualize, you can get all those things. Next investigation is angiography. You can put a dye into the blood vessels and through a cannula, and you can visualize the blood vessels. It's a medical imaging technique. These are radio-opaque dyes. You can study structure, lumen, flow dynamics. So you can see blocked valves, narrowed valves, large valves, blocked or enlarged blood vessels, or if there are malformed arteries or veins. Usually you do it to blood vessels of brain, heart, abdomen, legs, or anything else. So you can see this, when you do an X-ray, you can see this, right? It's called a radio contrast agent. You put a catheter and you send it there. So you can do few X-rays, or you can watch it while you're doing it. That is called an angiogram. So this is a cardiac angiography. Can visualize the coronary artery. Look at this. You are sending in a dye. Initially, you can't see this. Now you have sent a dye and you can visualize all the coronary arteries. Okay. So this, while the heart is beating. So angiography will allow you to spot problems in the narrowings in the coronary arteries commonly. So when you visualize, you can relieve a block, right? I told you physically you can, this is a block. You can put something, a little catheter with a balloon, and you can break this, sort of open this block. That is called angioplasty. Or you can put something else while you're doing the angiography. You can put a little thing like this, which can expand. It is called a stent. And you leave the stent and take the catheter out. And you see that, so that the block cannot become any bigger. So this is angioplasty, this is stenting. Finally, it's Doppler ultrasound, measures blood flow velocity with Doppler flow meters. Right? Now, what you will see is Doppler flow you may have learned in A-levels. The red cells are moving. You are sending a transducer. These ultrasonic waves are falling on the red cells. Depending on their movement, they are the whatever that is reflected is going back. And you can calculate the speed, whether they are open, closed. It's very easy. You can just carry it in your pocket. I mean, not in a pocket. You can carry it in a little case, and you can do with the portable Doppler. Okay. So the changes, reflected wave changes, are proportionate to the blood flow rates. So you can use the Doppler studies to check the flow in arteries, veins, heart, wherever. Right, we finished. So you learned about five important conditions: hypertension, high blood pressure, angina pectoris, myocardial infarction, these are myocardial ischemia, heart failure, and shock. And then you outline the principles of assessing cardiovascular functions using an ECG, cardiac enzymes, echocardiography, Doppler studies, and angiography. I'm not going to give you the questions polls because you have to be ready for the next lecture. Just simple things, okay? Right. So that's it. Any questions?